Welcome everybody to our Insight 2020 session. This is our 30th event, and today we're looking at how you go about accessing the code and data that underpins the decision support unit network analysis of healthcare use at the end of life. We did have a session looking at the analytical insights from the end of life report, and I've added a link to that into the chat so you can go and have a look at that. And the report that we're going to go through is available on the website, and I've included that link as well. Steve, if we go on to the next slide, just some standard housekeeping rules. Please do keep your microphone muted during the session. Do introduce yourself in the chat box. It's great to know who's here. And please do use the chat box function to raise any questions and tell us about any technical issues. We're recording the session, so we'll send you some links to anybody who's registered. And please do tweet about our sessions using the hashtag Insight2020 or tweet us at the strategy unit. Next slide, please, Steve. Today's speakers are the authors of our report. Steve Wyatt's going to give you an introduction. Steve is our lead analyst and is in charge of all the work that we do through the analytical work programme. And Justine Wiltshire and Tom Jemmett did all of the work, and they're going to take you through the technical details. So I will just hand over to Steve.
Thanks, Janine. So just a quick recap on the objectives for the session today. We want to provide a bit of an overview of the analysis that we published a few weeks ago into patterns of healthcare use towards the end of life. We want to describe the broad data sources that we used and the data tables that we created and all the analytical code that was developed to produce the report. And then finally, we want to explain how those assets can be accessed by others who are keen to build on the work that we've already done. Just a bit of background before we start. So each of the STPs or ICSs in the Midlands will be setting up a decision support unit over the next few weeks and months. Some already have done so. The naming convention is open to change. So some STPs are calling their decision support units by different names, but the function is the same. It's to provide a focal point for key strategic pieces of analysis or evaluation or evidence review within that STP to support the STP or the ICS to make important strategic decisions over the next few years. Now, as the units get set up, I'm sure some collaboration naturally would occur, but we don't want to leave that to chance. We want to, the STPs and the ICSs have asked that the strategy unit actively network each of the STPs, each of the DSUs within the network, to make sure that learning from one can be shared with another as quickly as possible, so that we can identify areas of shared interest between DSUs and make sure those different areas are collaborating and working together wherever possible. And one of the functions that the strategy unit will be fulfilling is to carry out 2 or 3 large analytical projects every year on behalf of the Midlands region. And it's our objective to try and share as much of the code and data for those projects as possible so that individual STPs and decision support units can use what we've done and take the work further. The first of those pieces of work was published a few weeks ago. That was the piece of work that Janine mentioned on healthcare use in the last 24 months of life. But there's 3 other projects that are due, the work is underway and they're due to be published in April next year. One on inequalities and access to mental health services for children and young people, what the consequences are for poor access in terms of healthcare use and health outcomes later in life. There's a project which is looking at inequalities and access to planned care, what the causes of that are and what the consequences might be. And a third project which is about classifying outpatient activity by function. So for each of those reports, as they become available, we're going to try and make a set of code and the data sets available to people so that they can take the work on. There's two ideas really behind that. The first is that we want to try and be as open as possible about the work that we've done. We want it to be possible for individual areas to be able to replicate the analysis that we've done, to understand the detail of it, but also to review it and check it for errors. And the more eyes there are on pieces of work, the more easy it is for us to spot errors and correct them and make sure the work is of high quality as possible. But also we want people to be able to build on the work that we've done. Inevitably, the work we do will always take a particular perspective, but individual local areas might want to take a different view on it. They might want to take a deep dive into a particular finding that we've highlighted, or investigate a particular issue in more detail. And if we share the data and the code that underpins that work, then that should make that process a little bit easier. This is a journey for us. We'll show you today what we've done on the end of life care project, but we're hoping to get better at this over time, to get more proficient with the process of sharing code and data. And I'm sure your sort of feedback today will help us on that journey. And what we'd like as well is for colleagues in DSUs, as they carry out work, to share their code as much as possible, and we'll try and provide some facilities to make that as easy as possible for areas to share their own code on the projects they've been working on. So that's the background. I'm going to hand over to, well, I'm going to ask a few questions on Mentimeter in a minute, but just to set the scene for this afternoon's this session. It's a very practical session, so we're going to take you through the nuts and bolts of what we've done. So don't expect fireworks. It is a very practical session where we're going to go through each of the steps we went through as we compiled the report. So I hope that's what you're expecting from us today. That's certainly what our plan is. There'll be an opportunity at the end for you to ask any questions of us, but keep them coming through the chat box, and we'll pick up on those and I'll try and address them at the end of the presentations. So before I hand over to Justine, I just wanted you to ask a few questions via Mentimeter. So if I could ask you to log on to your internet browser and navigate to menti.com, and then enter that 7-digit code that's on the screen there. And I'll change screens in a minute and show you the questions that we're going to be asking and some of the responses. The code will come up again in a second, as will the URL, so don't worry if you're still entering it into your screen. Hoping now you can see that screen. Quite a few people have already found it. That's good, entering the organisation that they work for. That's good. So we've got a few people from CSUs and from CCGs or STPs, one person from NHS England, and quite a lot of people from other types of organisations. I see we've got at least one person from university, and I think we've got Neil Pettinger on the line as well. I think he's from a private organisation. Welcome, Neil. Okay, I'm going to move on to the next question now. This is about whether you've got any experience in looking at or exploring or analysing people's health or social care use at the end of life. So it'd be good to know whether you've looked into this area at all in the past in your own work, just to understand your level of background knowledge on the topic we're going to be talking about today. It's not essential background knowledge, it's just useful for us to know what your level of knowledge is on this subject. That's great, lovely, thank you. And I've got just one final question for you. Which is about your level of understanding of a few of the data sets or programming languages or facilities that we're going to be talking about today. So we'd like to know what you know about each of these 5 things, and you can select on a scale from the far left, which is I've never heard of it, to the further on the right, which is you know a lot about this subject. And the 5 things we're interested in knowing your knowledge about is hospital episode statistics or similar data sets, those NHS commissioning data sets that we see in the secondary uses service. NCDR, which is the National Commissioning Data Repository. Transact SQL and R, which are the 2 programming languages we primarily use for this project. And GitHub, which is the code sharing repository and version control online software. So again, none of the knowledge of these is not essential for today's session. It's just helpful for us to know what people know prior to presenting, so that we know which bits to dwell on a little bit more and explain in a bit more detail. There we go, we've had 11 responses. I think maybe there's 1 or 2 more to come. Give it a little longer. So lots of knowledge and experience of people of hospital episode statistics. And most people seem to know a little bit about Transact SQL, but there's a few people on the call who know less about that. We're all in the middle of the distribution in terms of the programming language R, and a few people know about GitHub, but maybe we need to explain that in a bit more detail later on, as with NCDR as well. Okay, but that's been really helpful. Thank you for contributing to that survey. I'm going to hand over to Justine now, who's going to pick up the presentation from this point.
Hi everyone, so I'm just going to have to swap screens, if you can bear with me a second. Okay, oops, excuse me. Okay, so good afternoon. I am now at the right slide. So in the rest of this session, I'm going to take you through some of the key highlights from the end-of-life care reports. And we'll start with that just because I think it will give a sense of context that will then help with the rest of the session. I'm also going to take you through and explain the processes that we went through to process and produce the data that feeds all of the reports. And as part of that, I'll explain some key data items that we've also added to the data. And then we'll have a video where a colleague of mine, Tom, will be showing you how the actual charts and the visualisations were created. I'm afraid he can't be with us today because of some connection issues, but we've got a little video from him that you'll be able to watch. And then throughout all of this, I think Stephen's already mentioned about the transparency. So we're sharing all of our code and all of the data that we've created as well. And as part of this presentation, we'll show you how to access that. So before we look at the reports, I just want to really briefly mention the data and the sources of data. So early on in the project, there's a decision around which source or which supplier of the data to use. We decided to use NCDR, and I realise people may be a bit less familiar with that, so I will talk through NCDR in more detail later on. But the other potential source could have been HES, but we've actually decided to use the NCDR data warehouse for this project. And the data that we've used is the mortality data, so that's a record of everybody that's died when their death is registered, data is collected. And then we've got the activity around the mortality records. And it's important when we're looking for the right source or supplier of the data that it's all in one place, and that we also have to have a consistent ID across all the different data sets so that we can link people's activity all together. So this is the data we've used. I need to mention the data that we didn't use. We didn't use community contacts. Because although that is available in the NCDR their warehouse, it didn't go far back enough in time, and also it had some data quality issues, so it wasn't used as part of the reports. Also, if we think about a person who's at an end of life, they're going to have lots of other services wrapped around them, but those also weren't available to us, and they're just listed here, so you can see what else we didn't include, which is primary care, social care, ambulance data, and also hospice care, particularly for those approaching end of life. So what did we do with the data? Well, before we look at the actual analysis, the reports were for the Midlands. So if you look on our website under publications, you'll see the reports there for each STP within the Midlands, and also a Midlands version of the report. In today's session, we're just going to go through a few key highlights. You can see here the contents page, which would hopefully give you a bit of a flavour for everything that's in the reports, but that would take a little while to go through. So just a few key outputs today. So as I've mentioned, we did report in the Midlands, and in the following slides, they are at the Midlands level. I didn't want to pick a particular STP, so we're looking at everything at the Midlands level. It's just for adults. And it's all deaths that took place in 2018-19. Firstly here, we're looking to see how the number of deaths has changed over time and how we believe it will change in future. So historically, we see that since 2011, in most years, not all but most, there's been a year-on-year increase in the number of deaths, and also that the gap between genders has been closing. The predicted deaths, which are represented by the dashed lines, and they're available from the Office for National Statistics, show a continuous and sustained increase in the number of deaths is expected. And then also in the predicted deaths, we start to see males overtaking females for the first time, and that then continues higher throughout for males. So what does this mean? Well, services will already be caring for the decedent population and on a continuous basis. And as the size of that population is expected to grow, so too will the demands on services. Between 2020 and 2030, the size of the decedent population is expected to grow by 18% in the Midlands. So in just 10 years, a significant increase in the size of the decedent population. If we look at future decedent populations by age group, we can clearly see that the growth in deaths is for those dying when they're older, particularly those who are aged 85 and older when they die. So the specific needs of the older members of the decedent population are going to have a bigger impact on future demand. And just to mention that although we're displaying predicted deaths by age groups, the data underneath is actually by single year of age. So we do have the number of expected deaths for 74-year-olds, 75-year-olds, 76-year-olds, and so on. Now moving on to look at where people die. Overall, 47% of all adult deaths in the Midlands took place in hospital, but that profile does differ for different causes of death. The chart here is called a MECO chart, and it's quite similar to a stacked bar chart. It's similar in that it's got the vertical stacked columns, but it differs in that the widths of the columns also indicate scale. So here we see that the largest proportion of deaths, or the widest column, is for deaths in frailty. And within frailty, around a third of all deaths are occurring in a care home. And that's the highest proportion for that particular setting, as we'd expect for those dying from frailty. Cancer, that's the next highest cause of death, with around a fifth of all decedents in this group. And in this group, there's also the highest proportion of deaths in a hospice. Again, as you'd expect, given the nature of hospices around providing care for long-term incurable illnesses. There's very few hospice deaths in the other causes of deaths. Organ failure and sudden death both have a high proportion dying in hospital, although still approximately between a quarter to a third are dying at their home location. The other terminal illness, that's the smallest group within the population by far, and again in this group there's a large proportion of those dying in hospital. Looking at place of death by deprivation quintile, so here we have the most deprived quintile on the left, moving up to the least deprived or the most affluent on the right. And between quintiles, there were more deaths in hospital for the most deprived, and that seems to be almost a substitution with deaths in care homes, as the most deprived also had the fewest deaths in care homes. For deaths at home and deaths in the hospice, they do differ, but they're much more similar across the different quintiles. So we now know something about the decedent population. We know how many adults there are. We know how many are expected in future. We know about their gender. We know about their age. And we also know about their cause of death and where they die. But what about the services, the healthcare services that they access in the 2 years prior to their death? Before we look at access, I'll just mention how we categorise our data throughout the report. So we've grouped activity into 4 different activity types. So we've got urgent service events, planned contacts, planned admissions and bed days. And then within these there are a range of services included. So urgent service events, for example, includes emergency admissions, A&E attendances and 111 calls. And there are some areas of the report where we do go down to service level. So the actual access here, we're looking at access. So we have the proportion of the decedent population who access each activity type in the 2 years before they die, meaning the proportion of people who have at least one contact with these areas. So a large proportion of the decedent population, 95% of people, so nearly everybody, having at least one urgent service event in the 2 years before they die. For planned contacts, access is also high, with 87% of people accessing these. Planned admissions, access is lower, around about 40%. So 40% of the student population having contact with one of those services. And critical care access is much lower at 12%, so a small proportion of the decedent population having at least one spell in critical care. And then by the different services within each activity type, we can see access for emergency admissions and A&E are both high. Each of these are accessed by over 80% of people. For 111, access is much lower, but still 64% of the decedent population are picking up the phone and making a call to this service. And then in planned contacts, the majority of access is coming from access to an outpatient appointment, and then nearly a quarter of people having some contact with mental health services, and a very small amount for Wyatt. Within planned admissions, it's mainly a mix of day case and electives, around twice as many decedents accessing day cases when compared to accessing elective admissions. For critical care, we split this into critical care that's the result of an emergency stay or critical care that's the result of an elective stay. So we can see that when people in the decedent population are accessing critical care, it's much more often the result of an emergency admission. We've also looked at access by cause of death to see how this differed. It's noticeable here that cancer stands out in planned admissions, so many more cancer decedents are accessing planned admissions than those with other causes of death. For both urgent service events and planned contacts, there is a difference by different causes of death, but they're much more similar in those two activity types. And then when we look at critical care, a difference where access is lower for people who are dying from frailty. So beyond accessing services is how people interact with all services and to what extent. So now we're moving on to consider an end-of-life pathway and what those might look like. So here, as an example, we have just one patient with their healthcare represented as a sort of barcode over the last year of their life. The proximity to death in days is on the axis at the bottom there. So day 0 would represent the day on which a person actually dies, and then 365 days would be a year before that person dies. And here we can see a patient had a planned admission, and then they're staying in hospital for a few days after that. They're discharged before coming in as an emergency admission, and they're staying in hospital for around about 2 weeks at that point. And then they're discharged again. They have a planned contact, then they have another planned admission, but this time with no stay in hospital. And then the closer this person is to death, the more activity is happening to them, particularly around urgent service events. And you can see that in this example, this patient actually had an urgent service event and then went on to die in hospital. So that's just one example. Here we're looking at a random sample of 15 from the population who die from frailty, and viewing it like this allows us to consider whether there might be any healthcare experiences that are common to people dying from frailty. So here I would say that in this group most people at some point are staying in hospital after an emergency admission, but not so many people going on to die in hospital. For the cancer group, it's a much more dense picture, lots more activities happening. They often have a series of planned contacts, many planned admissions, and these where they're staying in hospital as well. And then urgent events and any associated bed days, they're generally taking place closer to death, particularly in the last 3 months of life. For organ failure, quite a lot of urgent stays for this group, and these often becoming longer the closer to death that a person is. And then the sudden death pathway. So for sudden death, there are planned contacts throughout the last year of life, then urgent bed days again cropping up, particularly at the end of life, and often in this group resulting in a death in hospital. So the other terminal illness group, this was quite a small group and a very mixed picture here, but it stands out that a proportion are having very long lengths of stay and more so towards end of life. And we see some urgent bed days here interrupted or intersected by urgent service events, and these are representing transfers between trusts. If we put the four main cause of death groups together, I think it's then when you compare them side by side, it makes it easier to see how the different pathways are between the different groups. So moving on from our random sample of 15, we're now going to consider everyone in the decedent population and what does their pattern of use look like by proximity to death for each activity type. So we start here by looking at urgent service events in the 2 years prior to death for Midlands adults decedents. And so we have the data points for each proximity to death. I've highlighted an example here. This shows the amount of activity taking place on day 0 or the day on which people die. And then with those data points, we have a curve that we've modelled through the data points. And then in our report, we've looked to describe these curves in a few short, simple sentences. And here, for urgent service events, we say that they start low, they increase slowly for much of the period. Then, in a few months prior to death, there's a rapid rate of increase, rising to a sharp peak. And then normally, when I'm doing this presentation, I give people a chance to reflect at this stage, and I probably won't do that today, just because I think we've got a lot more to look at with the data processing. But essentially, we have the other 4 types of activity with their charts below, and the idea is people take a few minutes just to reflect on which title they feel would go with which chart. But I'll just talk through these now. So bed days and critical care, they're quite similar. They're different, but they are quite similar, and they're similar in shape to the urgent service events in that they start low, they increase slowly, and they rise to a sharp peak on day 0. And the reason behind this is that bed days and critical care, as we've seen earlier, are mainly associated with emergency admissions for the decedent population. So their patterns of use are therefore intrinsically linked and are going to look similar. For planned admissions, they don't quite start from 0, but they do start low, and they increase steadily over the 2-year period. They come to a rounded peak at around about 3 months before death, at which point use starts to decline. And then planned contacts, they start higher from around about 15 activities. They also increase steadily over the 2-year period, and they come to a sharp peak in the weeks before death. So, because we have such a granular level of detail underneath the reports, we can consider utilisation in different ways. So the previous slides looked at utilisation for all decedents by their daily proximity to death. But now here, we're still looking at utilisation, but we're doing this for each age at which a person dies. Age is on the horizontal axis there. And we're now no longer looking at it by proximity to death in days. Instead, we have 2 different time periods. So we've got the first or final year, so 0 to 12 months. And then we have the second or penultimate year prior to death, which is 12 to 24 months. So on this first chart, which is at service level for A&E attendances, I'll explain this chart in a little bit more detail, just to help with understanding how age utilisation works and with interpreting this series of charts. So as an example, this data point represents all 67-year-olds, i.e. all those people who died in the Midlands aged 65 in 2018-19. And it shows how much activity they use on average in the first year prior to their death, which is around about 2.2 A&E attendances. If we look at younger decedents, here 52-year-olds, then we can see that use is actually pretty similar on average. And then at the other end of the age spectrum, people dying aged 89 highlighted here, they also have, again, a similar level of A&E attendances on average. So for the second year period in red, use of A&E attendances is again similar across all the ages. It is, however, much lower than the first year period. So what does this tell us? Well, it tells us how A&E is used by the decedent population, and it tells us that what influences A&E use is not age, but proximity to death. We see a similar picture for emergency admissions. For 111 calls, Utilisation is lower overall, but we do see here that after around about age 70, as age at death increases, so does use of this particular survey. Looking now at planned contacts, you can see that these are dominated by outpatient attendances, and just going through this slide quite quickly, that generally as age at death increases, utilisation of these planned contact services actually decreases. And then planned admissions, we can see that these are dominated by day case admissions, but again, as age at death increases, utilisation decreases. Looking at bed days, so clearly emergency bed days here are massive compared to elective bed days or critical care. The older the decedent, the longer they spend in hospital in the first year period. The very oldest are often spending around about 26 days in hospital. This is approximately a week longer than the youngest, who stay around 19 days in the last year of life. Generally for electives and critical care, as age increases, then utilisation decreases. So we know how much healthcare is used, and we know this by age, and we also know the size of future decedent populations by age as well. So in our report, we apply age-specific utilisation to the future expected decedent populations over the next 20 years. And this gives us the activity we can expect in future if utilisation rates remain the same as they are currently. So here we see future demand for urgent services at 5-year intervals and broken down by age group. You can see the older decedents, those aged 85 and over, they dominate the overall volume of activity, and also they drive the increases in demand for this type of activity. Just to mention as well, all the percentages are relative to 2020 on these charts. For the other types of activity, there's growth in all areas, and again, the growth comes from the very oldest. There's a particularly large growth in beds, and here the move from 3.1 million bed days in 2020 in the Midlands to 3.3 million bed days in 2025 would equate to an additional 556 beds being required in the Midlands. If we compare 2020 to 2030, then actually we'd need an additional 1,226 beds in the next 10 years in the Midlands to meet the extra demand. Beyond activity, in the reports, we also look at the resource that's consumed, which is looking at costs. So the total spend for the 2 years, not just in any particular financial year, but for the whole 2 years of end of life comes to 1.3 billion. If we look at that by activity type, we can clearly see that urgent services dominate the overall spend, and they equate to around about 2/3 of all spend. So that was the report, which are on the website, and you can look at the full versions. But now I'm going to move on to talk about how we've processed and prepared the data. So I've split this broadly into 4 different stages or sets of data. And the first one is around about the data source that we chose to use. And then the 3 there within the rectangular box, they're sort of internal and specific to this project. But I'll talk through each of these now in some more detail. So the first stage, we've already said we had to decide on our data source, and we wanted to use NCDR, the National Commissioning Data Repository. That is a large and comprehensive data warehouse containing lots of health services information, and it is hosted by Arden and Jen Discro and managed by the data services team at NHS E&I. So if you're unfamiliar with NCDR, it's a great data warehouse, and it's very similar in some ways to HES. It's the same sorts of information. It's SUS files, mortality files, and lots of data sources that you'd be familiar with, but just held in this particular warehouse. The reason that we chose to use NCDR rather than HES was because NCDR is much more timely, the data is much more up to date. And also that in NCDR, they do a lot of derived fields. So as an analyst, it makes our lives a lot easier if lots of fields we're going to use are already created for us. So that's another reason why we decided to use the NCDR data source. If you'd like to find out more about NCDR, there's a link there. But also if you do use the warehouse yourself, there's a data catalogue that lists all the tables that are in their warehouse and all the columns and describes the information that's in all of those columns as well. So moving on to what's specific to this project. So our first task was to set up a purpose-specific data mart, or PSDM. And that's basically because we're using so much data and linking it together, and in particular, the mortality file, to meet the IG sort of controls that we have to. Data is taken out of the main warehouse and put into a sort of separate area. And part of the sort of overriding principles of a PSDM is that you should only take the minimum amount of data that you need for your project. And if you want to find out more about PSDMs, there's a link there as well that you can look at. But the idea is it's a sort of separate area where access is controlled and just the minimum data required is available. So as part of meeting the IG requirements and just taking the minimum data, we had to think about the columns of data that we wanted. So it's quite a large exercise at the beginning of this project to look at every table in NCDR, pick the tables we wanted, and pick the columns from those tables that we wanted to be available in this project. But also we had to have just the rows or records of data that were relevant. So for the mortality file, we just have records where the death took place in 2018-19. And then for the activity files, it's records where the person has died in the mortality file. So they died in 2018-19, but also its activity over a 3-year period. So that's activity from 2016-17 up to 2018-19. So in the reports, although we're analysing 2 years worth of data, we need to have the 3 years of activity so we can include 2 years for everybody. So for example, if somebody actually died on the 1st of April 2018, we need to be able to go back to the 1st of April 2016 to get their full 2 years. And then this slide I find particularly hard to talk through, so bear with me. But if you think back to the sort of star diagram that I showed right at the beginning, where we had mortality and we had the activity around it, that's sort of represented by the column on the left here. And then you've got the standard NCDR. So if I take inpatients as an example, we knew we wanted inpatient data. Within NCDR, there's an array of tables related to inpatient data. And these are the 3 that we felt that we needed for our project. So the first one on the list there, if you're familiar with NCDR, you could probably type these table names in your sleep. If you're not, I'll just explain them in a little bit more detail. So the first table that ends in APCS is the admitted patient spell activity. But then you've also got a sort of a separate table which contains the cost information under the 1819 costing rules, and also the derived fields that I mentioned earlier. There's a separate table with those fields in. And then the base data was put into the pseudo-specific data, the purpose-specific data mart, and that was called for this project NHSE BB5008. So basically, we asked for data and we were given the data at this point, and we've called that base data in terms of explaining it in this presentation. So not much work for us, we were just given data files at this point. The next stage was where we started to have to do some actual work and derive some data tables from the data that we've been given. So you can see here the base data tables and how the names of the tables that we then derived. And you can see sort of there's an MPI and then all the different activity files. When we were creating our derived tables, we didn't pull all the records from the base tables. We just pulled those where the death wasn't cancelled. This is very small numbers. I think it's something like 37 out of over 500,000 deaths, but it's just to explain to you, the criteria that you'd see in our SQL, why it's there. So we've excluded any deaths that were then cancelled. Because our report is just dealing with adults at this stage in the process, we also exclude anybody who was under the age of 18 when they died. We also exclude any null IDs because we're linking the data together for people, so we need to make sure we've got a valid ID. Also, we just at this point pull in SDPs for England. So I think in NCTR there is some Welsh activity, so that's excluded when we derive our tables here. Also, at this point, activity has to take place within the 2 years prior to death. And just to help me explain that well enough, I've got here a completely fictional example where there's activity across a 3-year period. And my fictional example, the person's died on the 3rd of March 2019. And then so in the derived tables, if the activity, the 2 years is there, sort of 2nd of March 2017, so what's included in the derived tables is the activity that falls in this range. And what's excluded will be activity that takes place more than 2 years before death. And then final exclusion. For each type of activity, so outpatients will be different to inpatients, will be different to A&E. There are some very small exclusions related to data quality, but very, very small numbers there. But they'll be in the SQL code, but they're specific to the different data sets. So the derived tables, they also contain some extra columns. So if you're using the SQL or you're using the tables, you'll see those there. In the main, they're about just making the data appear how we want to make it appear. So the activity types, for example, were sort of columns that we've added to make the data appear how we want it to appear. But there are a few columns which are key and which may be newer to people. So I'm just going to talk through these in more detail. There's cause of death, location of death, and proximity to death. So the cause of death group, the field or the column is called cause group LL, and it's based on some work by doctors Lynn and Lunny, who were that sort of came up with these 5 different causes of death groups that we've seen used quite heavily in the report. And their work's actually based in America, so the American data is very different to what we have in this country. So we also utilise some work done by the National End-of-Life Care Intelligence Network that allows us to take the UK data and put it into the Lynn and Lunny groups. And the way that we do this is we take the underlying cause of death. There's just one underlying cause of death per person, and that's an ICD-10 code. There's some more information there on the screen if you're not familiar with the mortality data, to have a look perhaps at the user guide, the ONS user guide to mortality statistics. That would explain all of these fields in more detail. But we take that underlying cause of death and we map it, you see in the SQL code, to one of the 5 cause groups. The one that's tricky is the frailty data. And again, we use the work done by the National End-of-Life Care Network, who came up with an algorithm whereby people who died based on their age at death, sort of a random percentage of those people were put into the frailty group. And because of that, because of the sort of random nature of just assigning a certain percentage of people, every time that you run that algorithm, the results on a unique person level basis do change. So what we find is no matter how many times we run it, the overall characteristics of the frailty group stay the same because it's quite a good algorithm in that way. So the average age is the same, the gender splits would be the same, and the healthcare use would be the same for the group, the frailty group as a whole. But obviously individuals would change between different groups every time we ran this code. To get around that, because we don't want the data to keep changing, makes it difficult for us as analysts if our results do change even very slightly. We have an MPI fixed cause table in the PSDM. So you'll see that we just derive the cause of death once and then link on a patient basis to get the cause of death from that fixed table. I should mention as well, although frailty is a random element and most people end up in the frailty group because of that, there are also a few additional codes that are ICD based, I think around Alzheimer and dementia and those kind of conditions. Those are actually done directly from the ICD-10 coding for frailty patients. Next, looking at the place of death or location type. It's based again on guidance from the National End of Life Care Intelligence Network. I wish that was shorter to say, but it uses 3 fields that are in the mortality data set: the place of death code, the place of death establishment type, whether it's home or other, and whether or not it was an NHS establishment or not, to put it into one of the location types that we use in the report around place of death. Here, I realise it's probably very tiny on everyone's screens, but it's just a screenshot from the report where they talk about which, in those tables, which code should go into which place of death group. And then, because I feel that I keep mentioning the SQL, it's almost fictional at this point maybe to people. Here is a screenshot of some of the SQL code where we take the information on the left and we apply it to the data. And when you access, or if you access SQL code, you'd see that that code there available for you. Proximity to death was the final key field that I wanted to mention. In some ways, it's quite simple. It's just the date of death minus the activity date. But we do have it calculated in several different ways. So we have it calculated as days, but also months, and those are complete calendar months that how we've calculated it monthly. I think when we started off, we planned that we would do the analysis, the proximity to death analysis on a monthly basis. But actually, when we looked at it on a daily basis, which is what you see in the reports, it was much more interesting because so much changed. But all those fields there available for you. Should mention with a warning that the proximity to death also contains negative values. So what's happening there is that there's activity recorded on a date after someone has died. So if you use these tables and you think, well, what's going on here? It's because of the data that's been recorded, and we leave it in at this stage. Obviously we exclude it from the actual report, but we left in at this stage because we just wanted to be able to make an assessment of how much activity it was sort of amounting to and how many people it was affecting, just to make sure that what was in the mortality file was pretty much correct. Then that's the end of everything we went through in the derived data. So I'm just going to talk about the reporting data. So we had our constructed tables, and then we had our reporting table. And there's 2 of those. There's the activity, and there's the cost as well, the all mids cost table as well. So how we did those, again, the SQL code for sort of unioning those tables together and doing a bit of formatting, that's also available for you to see. But I would just like to stress it's very personal deciding to put those tables together in SQL. I think in retrospect we do it perhaps differently and wrangle the data in R, but at the time we just brought it all together in SQL. At this point, the negative proximity to death, any activity that's negative is excluded because we don't want to include what's obviously a data quality error in the reports. And also a final comment from me just around how we use the MPI, the Master Patient Index of dead people in this project, to sort of define different bits of information. So people will move around, they will move STP, they will move their area. So we just want people to appear once. We don't want people to appear in the same report for different areas. So anything that's related to the person, age, that is their age of death. STP is the STP that they were registered with when they died. The deprivation, that's the deprivation that was registered from the area that they lived in when they died as well. So just if you are using the data and you want to understand how we've calculated that, we want it to be a fixed point. So that's how anything that's related to demographic data is sort of handled in the data and in the reports. Having talked through what we've done, hopefully people will also want to access this and do their own local analysis. So the first step is to have an NCDR account to access their data warehouse, and those are available for CSU staff. And then if you have access to NCDR, you can also request access to the PSDM, and the names there again, NHSE BB 5008, and you would find all the tables that we've created are in that area. All requests for access should be made to the NCDR help desk. The email address is there on the screen, and they will I think sends you a form and you have to complete the form to get access as well. So it's coming to the end of where I'm taking you through the different processes. But my colleague Tom, who's done a little video in the next section, he will also talk about, with his code, he used the NCDR data science server. It's just another area of the warehouse. And again, if you wanted to run Tom's code, which is the code that produces all the charts and the visualizations, you'd have to have access to the data science server. And you would do that in the same way you'd contact NCDR help desk on the email address there and request access. So I'm just going to play you this video now. Okay, so that was the end of Tom's video explaining how the actual charts and visualisations were created and how to access those. I think we might be a little bit ahead of schedule, which could be good news for some people maybe, but we can move on now to the discussion section. So there's some questions here, and I think Janine might also bring a few things up from the chat box that people might want to talk to us about.
There's loads in the chat box. Steve's been answering some of the questions as we go through. Steve, do you want to come in and kind of, I think there's one from earlier on.
Well, there was a question that was asked about the projections that Justine was sharing. I just wanted to talk through the process we went through to produce those activity projections. So we're fortunate in this situation that ONS have done all the hard work for us, really. They've produced some projections for the numbers of deaths that will occur within each CCG by single year of age at death and by gender for the next 30 or 40 years. That's the really complicated bit. And so we should produce our own projections for deaths by single year of age because we didn't think we were going to outperform a whole team of demographers at ONS who work on this on a daily basis. So we've taken those projections by single year of age and gender and CCG. We know from our analysis what the rates of use are for people who are approaching death by age and gender. And we've assumed that those utilisation rates by age and gender and proximity to death won't change. But we've simply applied those utilisation rates to the number of people that will be dying in the future within each of those areas. And that gives us an estimate of the level of resource use or activity that we might expect for the group in the future. Important to point out that does mean that the sort of key assumption that makes is that people's use of health services, given their age and gender and proximity to death, won't change. So it kind of sets out the challenge if we don't change the way in which we deliver services to people who are dying. Clearly what we would like is rather than build an extra 1,000 beds in the Midlands to accommodate that, when we know that most people don't really want to die in hospital and a lot of maybe healthcare use towards the end of life is probably non-beneficial, that we'd rather find new ways of delivering care to those people which both improves their quality of life, the quality of their death, and has a lower or a different burden on the health service.
Thanks, Stephen. There's a really good thread through the comment from Alex around what's happened during COVID. So clearly your analysis is finished and will largely predate the pandemic, but it's kind of, do we know if the use of acute care changed during the COVID period? Has it had an impact on people turning up for things like their outpatient appointments? Has it impacted on DNAs? Really, just has it changed what we see through acute care and through the end of life care pathway because it hasn't been easy for people to get into hospital?
Yeah.
A really interesting question. I've had some conversations with a group called Nesta who particularly wonder if COVID will in the long term sort of actually reduce deaths in hospital, because during the pandemic, you know, sort of been more conversations and perhaps people less willing to go to hospital if it's not actually sort of a life-saving situation. But our data, because it's 2018-19, so it's deaths, the last day would be deaths occurring on the 31st of March 2019, so it definitely predates COVID, so there's no effect from COVID in our analysis. But also when we've talked to commissioners and other people, in a way this is the business as usual situation for the NHS. Although COVID's happening sort of right now, actually in future years people are still going to be dying from cancer, from frailty and from basically non-COVID related reasons. So I think that's just a sort of reflection, although we also think about COVID, and that's interesting. This I think has a value because it's before COVID. It talks about a much more business as usual situation for the NHS.
Just to pick up on a question that, that Neil's just added to the chat about resource use. So there is some stuff in the report about resource use of people approaching the end of life, but the costs, but also the physical resources that they consume. And Neil's put a comment in about how many people, well, how many beds are used typically occupied by people in their final year of life. I don't think that's in the report per se, but I know from earlier work we've done and from work that others have done that it is a substantial proportion. I think if you were to walk around, I think the stats suggest that if you walk around any given hospital on any given day, about a third of the people who are in beds won't be alive in a year's time. It gives you an idea of the proportion of the hospital resource that's consumed by people who are approaching death. And the question is whether hospital is the right place for all of those people. It will be for lots of them, but for some people, hospital is the default place to go rather than the most appropriate place to go. And that's kind of the challenge I think we're facing over the next few years. You know, looking at the scale of the increase in the numbers of deaths over the next few years, I think we've got to find different ways of providing care and support to those people other than through hospitals.
There's an awful lot of support coming through in the chat for sharing, and thanks for people around the fact that we are trying to share and we are making the code open source and available, but also some barriers coming through around NCDR access. Some support from Alex offered around the fact that the NHS England team who established the NCDR are kind of really keen on it being made more widely available to people with a legitimate legal basis to access. But I think genuine support for using the data and using the code, but something for local systems to try and figure out around their access to data.
Yeah, very few data access applications are straightforward. I think if you're in a CSU, then actually access to NCDR is fairly straightforward. They have really streamlined that process, but it may be slightly more tricky and convoluted a process for people outside those settings. But I sort of agree with Alex. They have been very supportive of us using the data sets. They seem to want people to use their data sets. And yeah, let's see if we can find a way through. For anyone who gets stuck in that process, who thinks they've got a good reason to access the data but can't quite manage to get in, let us know, and we'll give whatever support we can to give you to get access. Yeah, we have to think sort of imaginatively about how we go about this. Obviously staying within the regulations, but we may need to think imaginatively about how we can find a route through this for people.
Yeah, and it's nice that people, you know, that the idea of sharing it can be a bit scary actually. I was frantically tidying up some code this morning just in case it looked terrible. So it's nice that that's something that's positive, and maybe by sharing what we can share at the moment, then, you know, perhaps there's more people who will be inquiring about NCDR and inquiring about access that kind of wouldn't have otherwise.
You'll have to go easy on us. So this is our first really big experiment with code sharing. So don't tell us how terrible it is. Be gentle with us if you have to tell us there's an issue.
Yeah, Tom's will be fine. It'll just be my SQL where it'll be untidy and people will think, oh. So I do hope people use it if they need to find the faults with it.
Just picking up Helen, Stephen is saying that it's straightforward if you're in a CSU, a commissioning support unit, not the DSU. So the so Midlands and Lancs CSU, Odden, Jemmett CSU, the kind of tier of data processing, but CCGs should be able to apply for some sort of access through the CSU, but it's all through the NHS digital route for application. A follow-up from Neil around his question around the resources that people in their end of life use, around actually how we'd go about marrying up the person-based analysis with the institution-based analysis. Stephen?
Yeah, I think I could see what you're getting at, Neil. I haven't got any great thoughts on that at the moment, off the top of my head, but I can definitely see where you're coming from. If you have any ideas about how we might look into that, I'd be really happy to talk further, either now or after the session or at some later date. But I can definitely see there's an angle there that that would be useful exploring. Thanks, Neil.
There was a question right back at the beginning for Justine around how you define frailty. I'm not sure whether you answered that in the presentation.
Yeah, I think Stephen did mention to the person that asked that question I would cover that. I hope that I've covered that, explaining sort of the random nature and how we fixed it, that we did investigate that if you use this random element, the group itself as a whole, the characteristics are the same. But again, I think there's a slide slightly further on which has got my contact details and Tom's contact details, and also a sort of generic strategy unit address. Should any of us disappear, then you can always, if there are follow-up questions, we'd actually love to hear from people, and we'd love to kind of get more people looking at this particular subject. So just drop us a line if there's anything else after this session.
There is a huge amount of support in the chat for sharing code and making things kind of transparent and open for analysts working in the public sector to replicate what they're doing, peer support and learning for each other. So throwing that back to our audience, what other things do you think we can do through the Decision Support Centre to try and support that across the Midlands, but also widening out to other areas in the country, because it's that transparency needs to be as open as we can make it?
I think I mentioned at the beginning of the session that we've got 3 other projects underway, so we'll go through a similar process for trying to share the underlying data and the code for those projects, but accepting that we won't get it right first time. Let us know if you think there are things that we can do to improve this process that we're going through, other information that we can make available on the GitHub site, or if we find there are ways of streamlining access to the data, let us know. We'll try and improve those as well. But yeah, any thoughts you can give us on how to improve that process, please let us know. I think that'd be really helpful. And it doesn't have to be today. At a later date, you want to get back in touch with us, please let us know. If you've got any thoughts or ideas about that sharing process, we'd be really keen to hear that.
There's no more questions coming in, Stephen, so it feels like we're coming to a natural conclusion of the session.
Before we do, there was just one point I wanted to mention. I think I was just having a look through the chat box because I couldn't look at it when I was presenting, but I think somebody mentioned outpatient appointments, and I just thought I should be clear there that actually it's just attendances. It doesn't include DNAs in the report, although the base data, the green colour, the original files that we got given by NCGR, DNAs are in there, but they aren't actually in the reports, and I should have been clear about that. So I just wanted to mention that to whoever asked that particular question. Sorry.
I just had one more point to make before we wrap up, which is I should have made earlier, but when Tom was running through the code that produced the markdown files that produced the report, whilst that will update the charts and any of the numbers in the text, it won't update the sentiment of the text. So if you're going to use that facility, you'll need to go through the text to make sure that the wording that we've used still fits with the findings that emerge from the analysis for a particular area that you're looking at. And that's no short process. It's an really important part of the process that you convey the meaning through the text, the charts and the data gives you. If you're going to go through that process of replicating the analysis for an area, then make sure you build in enough time to go through all the text and make sure you're comfortable with what it's saying before you sort of press the final button and send the report there.
So just to wrap up, a huge thank you to our speakers today. Contact details in the presentation for Steve, Justine and Tom, or do just get in touch via the strategy unit at strategy.unit@nhs.net. Massive thank you to our speakers. We're into our last week of the festival this week, so we've got 2 sessions left after today. We've got a session tomorrow with Al Mully, which we think is going to be really exciting, which is about exploring, I don't know how you say that word, pyramidal 3 dialogue framework to address the decision quality challenge. So it is a follow-up session around decision quality, and our final panel on Friday around decision making and what's next, which is a really good opportunity to think about everything that we've looked at across the festival and how we take this forward as a group going forward. So a massive thank you to our speakers and to everybody who's taken time out of their day to come and join us. Don't forget about the R conference that's also going on at the moment, and making sure you keep an eye out on what's going on there. And a big thank you to Stephen and Justine and Tom for putting today together. Thanks, everybody.